Our speaker is Dr. Aggrey Dhabangi, who's faculty in Child Health and Development Center at Makerere University College of Health Sciences in Kampala, Uganda. He will be speaking on transfusion in children in Africa.
The goal of this presentation, we shall highlight the transfusion guidelines, especially in pediatrics, a few practical considerations, like when to transfuse, how to transfuse a child, and a few advances. Yesterday we saw the past, the present, and the future. So what does the future hold for children in regard to transfusion? And this photo, just the message here is that transfusion in children saves lives. This child came in very paper white, and after transfusion 2 days later is on his way back home. Safe and saved. In transfusion, Dr. Henry has kind of highlighted this. What is the goal for transfusion? It's basically to raise the cell mass to relieve hypoxia. So you only transfuse if the anemia is severe enough to cause inadequate oxygen supply to the tissues. Otherwise, you are better off treating the underlying cause of the anemia, as well as looking at other alternatives that can actually optimize oxygen delivery to the tissues, like giving supplemental oxygen, improving the cardiac function, and at least you can save that unit for somebody who needs it most. There are guidelines for transfusion, and in sub-Saharan Africa we often kind of use the WHO guidelines, and one of them is basically a checklist to kind of ask yourself, do I need to transfuse this child? There are about 10 items. I just highlighted 6 of them. So before you give that child blood, you ask yourself, you know, what is my target clinically? What do I want to improve in this child's clinical condition? And can I minimize blood loss so that I can save that unit? Another, so that you reduce the need for transfusion. And are there some other treatment I could offer before starting a transfusion? Henry was talking about the tranexamic acid fluids, you know, that you could actually give in. Isaac has also talked about fluids in trauma. I mean, would you need to give this before transfusion? And what are the indications, both clinically and laboratory-wise? Often, sometimes pediatricians just, what's the child's HB? You know, it's 4, so transfuse. But that's just the laboratory indication. What are the clinical indications? So what is the clinical status of this child that it warrants transfusion? So look at both clinical and laboratory. And indeed, there could be other options in case blood is not coming forth. Do you have plan B? And you put yourself in the child's shoes, or the mother's shoes or father's shoe. If this were my child, would I transfuse, or would I accept a transfusion? And if you say yes, perhaps you can go ahead and transfuse this child. So we have WHO guidelines for transfusion in children, and we shall highlight this. And in children, the burden, like Dr. Dorothy yesterday highlighted, the need for transfusion in all population is basically from children, taking up 45%. Now again, in this subpopulation of children, the need for transfusion is mainly for malaria. So most of the WHO guidelines for transfusion are basically based on malaria, because it takes up the greatest burden of the disease of anemia in children. So the graph down here shows basically the burden of malaria. In 2007 to 2009, we did a research in Mulago we're just describing malaria syndromes or syndromes of malaria, of severe forms of malaria. And as we know, malaria, anemia, cerebral malaria, as well as lactic acidosis are the commonest fatal malaria complications. We had a population of about 855 children. It was an observation study. So we saw 855 children with severe forms of malaria. And out of 800, 558 had severe anemia requiring transfusion. That takes up about 65%. So if you are to look at only severe forms of malaria, 65% require a transfusion. And that's quite high. So what are the guidelines? When should you transfuse a child? What does WHO tell us? So there is a blue book which is entitled WHO Hospital Care for Children. The second edition is the current, as for last year, 2013. It's very common, it's just pocket size, and most clinicians have this. So on page 160, it stipulates when should you transfuse a child who is anemic with malaria. And the first category, they recommend that you should transfuse any child whose hemoglobin is below 4, regardlessly of the clinical indication. But this is more of a laboratory indication. And then the second category, which is a bit pragmatic, is with children whose HB is above 4. They talk about 4 to 5, if that is more laboratory. Now they combine it with a few clinical features. We talked about the indication for transfusion. Ideally, should combine both laboratory and clinical. So this second category looks at both clinical and laboratory. So the laboratory, HB ranging 4 to 5. However, if there is shock or detectable dehydration, if the child is unconscious, in respiratory distress, with heart failure, or hyperparasitemia of above 20%, parasite red blood cells. That's what it says on page 160. In the same book, on page 380, talking about the same topic, when to transfuse a child with anemia from malaria, they say, of course, the first category remains the same, HB below 4, 4 or below, regardless of the clinical situation, transfuse. Or if the HB is between 4 to 6. You see the difference? Same WHO international book, talking about two different thresholds. On one page, 4 to 5, another 4 to 6. So what do we take? Yet this is a world recommendation. And then, of course, the other parameters are the same. I mean the clinical indications. And then on the fifth clinical indication about parasitemia, whereas on page 160 it talks about parasitemia above 20%. On page 308 it talks about parasitemia above 10%. So which is which? So this highlights the gaps we have in our recommendations that we often adopt. And indeed, Kaja was highlighting, I liked that aspect of sub-Saharan evidence. Do we have sub-Saharan evidence? Well, this is a guideline, but is this sub-Saharan evidence? So from that piece, we see a few issues. That most of these guidelines, the evidence base is weak. And most of these recommendations, guidelines, are basically based on consensus. Indeed, my colleague Philip yesterday talking about sickle cell, and he was highlighting the guidelines, the NHLBI guidelines for transfusion in sickle cell. Many times he was reiterating the thing that most of the recommendations are by consensus. As clinicians, We need evidence. I don't think consensus is the best way to go. And no wonder, if we are going to come up with guidelines after sitting in conferences like this, and we go by consensus, it will have consequences. And it's not surprising that most of the transfusion guidelines across sub-Saharan Africa, they kind of vary, you know. Here we are doing this, the other side they are doing this, and it's not a good situation. Now, this therefore gives us an opportunity, like Isaac highlighted, to generate sub-Saharan evidence. In the local dialect, there is a saying, literally meaning that, it's a proverb, that in the abattoir or slaughterhouse, when the cows are mourning, it is an opportunity and it's a moment of joy for the dogs. You know the saying, nakuyechi? Yeah, so literally meaning that when the cows are really mourning and in pain and distress, the dogs are waiting for a moment of joy. So we may criticize the guidelines. We may find gaps in the guidelines. And we may weep and say, oh, you know, we need, you know. But this is an opportunity for us in Africa, in sub-Saharan Africa specifically, to generate sub-Saharan evidence. And I will just highlight some of these opportunities, drawing from the recommendation, and especially looking at this category of where we combine both laboratory and clinical indications. And from this we see so many opportunities. An example, looking at the category of threshold above 4, you know, they are moderately anemic, but they have other clinical indications. They talk about detectable dehydration, that we should actually transfuse if the HB is above 4, but the child has detectable dehydration. Now, clinically, what is the treatment for severe dehydration? It's rehydration, not transfusion. So this kind of clinically sounds odd, but it's a recommendation. So isn't there an evidence, an opportunity here to generate evidence? We could actually do trials comparing corticosteroids versus transfusion. A child is HB6, but he has dehydration. Clinically, we know what's the treatment for dehydration, but WHO is saying that, oh, this child may also need a transfusion. We have no sub-Saharan evidence. Can't we generate this? We compare, and then we shall have sub-Saharan evidence. The other category is heart failure. Now, in pediatrics, there is a thinking that if a child is anemic, also may be in heart failure. Clinically, this has been disproved, that most of the children who are severe anemic actually are not in heart failure. But we don't have the evidence. No one has actually come up to tell us the incidence. How many of these children who are severe anemic are actually in heart failure? We don't know. Now, if we don't know, yet WHO is telling us, oh, you can't transfuse this child. We need evidence to actually demonstrate that maybe this proportion with heart failure by doing maybe cardiac ultrasound scan, doing BNP measurements. There is a clinical trial we are doing in Mulago, and like I said, we have all the opportunities. So we are in the second year and almost closing, and we started doing BNP measurements for these children. And you can be shocked. The HB may as well be 4, and the BNP is below 15, you know. So yet routinely people are giving intravenous diuretics. A child comes in, severe anemic, is getting transfusion, or also give a diuretic, you know. There is no evidence for that. Well, the last category about hyperparacytemia, this also has been controversial because few research has come out to actually demonstrate that when a child has malaria and they are also hyperparasitemic, this factor, hyperparacytemia, is not a predictor of their progression to anemia. It is not a predictor. And so if it is not a predictor to progression to severe anemia, why should WHO recommend that a child with malaria and they have hyperparacytemia, they are moderately anemic, transfuse them. Again, another gap there. So again, an opportunity for us to do some clinical trials. That kind of child, should we do, like Henry says, restrictive and liberal, you know? Give, as they say, transfuse, because that's the deputy, but then also restrict, don't give them. And let's see what evidence we shall generate. That was when to transfuse, with gaps and opportunities. How about how to transfuse a child? Again, WHO also puts its foot down and comes up with evidence that are not sub-Saharan best. So, there are guidelines on when to transfuse, how do I monitor a child during transfusion, and this is a child who is getting transfused, and the moments later is up. So what must you do to get them to the other side? How to transfuse, it talks about products. The recommendations are that you either can give red cell concentrates, or you could give whole blood. However, they say the preferred are the red cell concentrates. On volume, it's a bit liberal. It says you can give 10 mils of the red cell concentrates or 20 mils of whole blood, tapering that down to 20 mils if the child is malnourished. On duration, it gives us 3 to 4 hours of transfusion. Again, equipment is non-committal. You say you can use an infusion device, like an infusion pump, if it is there. We don't have this often, and so we give by gravity. So these are the WHO recommendations on how to transfuse. The question is, are we really giving the correct volume? Just to pick one of them. It talks about product, it talks about volume, duration. Each of these have issues, because most of these guidelines, it was consensus, no evidence-based. So I just will highlight the issue of volume. Should we give, if a child walked in the acute care unit with a hemoglobin of 2, another with 6, should we transfuse them the same way with 10 milligrams per kilogram body weight of packed cells? Should we? Research has demonstrated that when you transfuse a child with packed cells or red cell concentrate, you are going to raise their hemoglobin to by 2.5 to about 3.3. So this child whose hemoglobin is 2, if you give them that dose or that volume of blood, 10 mils per kilogram body weight, you are going to raise them to maybe 4.5. Whereas the other one is going to, from 6, they will go to 8.5. So the question is, should you transfuse them the same way? The answer has not been generated by sub-Saharan researchers. We don't know. And this is an opportunity. In this study I have highlighted we just looked at this. After enrolling 100 patients, we have this kind of big group, all severe anemic. So we just subgrouped them and looked at those whose hemoglobin is very low, below 3, versus those who are above 5, you know, and looked at them. They are all getting transfused at the same rate and the same volume that as recommended by WHO, 10 milligrams, because we cannot do anything that's outside recommendation until evidence is generated. Much as you may have issues, but you have to go by what the recommendation is. This is what we just found. It's not yet published. This is just halfway, because this was out of 100 patients enrolled. So this is just the median HB of these ones whose HB is below 3. So pre-transfusion, they are about 3 also. After transfusion, at that volume, they are slightly above 5, maybe 5.5, compared to the other group, where their HB is above 7. And you cannot clinically see that these two groups of children are not the same. Yet, it is your role to put them almost at the same clinical and laboratory status. So, other researchers have actually come up to throw more light on this, that the way we are transfusing children, using the WHO guidelines, we actually are ending up under transfusing several children. Up to 35% of our children are actually under transfusion. Under transfusion is this kind of thing. The child is severely anemic, you want to push them above 6, but after the clinical maneuvers of your transfusion, they are not above 6. So that's an under transfusion. So, and this 35% is quite high. And other studies have said that this percentage can even go above 50% if the child is severely anemic, like child comes in with an HB of 2. So, what are we doing? Have we sat down to think about what we are doing? That is, how do you transfuse? WHO also gives recommendation on monitoring. If a child is getting transfused, what do we do to ensure their clinical well-being? It tells us about checking the respiratory rate, heart rate every after 15 minutes, looking for signs of heart failure, as well as the transfusion reactions, like Professor Hume yesterday took us through this, and checking a follow-up HB. Although they don't tell us when. When should you check? Is it 2 hours? Is it 5 hours? Is it 24 hours? These are recommendations. How is transfusion in pediatrics different from other areas like Kaja's areas and Henry's areas? Indeed, there are so many differences. Children are not small adults. Children often present with severe anemia with hemoglobins much, much lower than any other subpopulation of anemic children. It is not a rare thing to see a child with a hemoglobin of 2 coming to acute care unit. And they often present with respiratory distress. When they are severe anemic with respiratory distress, and most of these coming with the respiratory distress, it's because of their lactic acidosis. They are trying to blow off these metabolites. Note that they are in heart failure, like in adults. If you see a child, an adult who is breathing away, you can't think about heart failure, especially if they are anemic. But in children, it's the reverse. It's likely to be from metabolic acidosis and not heart failure. So beware. The practice of generously giving them diuretics needs to be looked at. And then, again, talking about diuretic use, most of them are hypovolemic. Their volume is really constricted. But yet we see some hospitals, they give diuretics every time they are transfusing. What are we doing? Do we have evidence for what we are doing? Again, the WHO tells us this, but also it's a fact that most of these children who are severely anemic, they will have several things, a combination, a myriad of things. And they say if a child has so many of these clinical events like acidosis, they are hypovolemic, they are just, protracted, you may have to transfuse them slightly faster. Much as they put their foot down, say 3 to 4 hours. But if you see them, the child has so many of these things, you may have to move slightly faster, like you can run a transfusion over 2 hours. And then Dr. Natkunda yesterday was telling us about the alloimmunization in transfusion. In children, especially most of these children are getting a transfusion for the first time. Again, the risk of alloimmunization is not so high. Not that it does not happen. Like for the population of sickle cell, they are getting transfusion several times. But for the others that are malaria, anemias, they are getting a transfusion for the first time. The risk is not as high as the adult population. However, issues with the ABO is a big, big issue. And then there is the fear that perhaps when you give blood that has stayed long in the fridge, there's this accumulation of potassium. You may actually cause the same thing in the patient. Well, is this clinically true in children? Maybe not. The last part of my presentation, I will highlight the future. What advances? When you go to a home, or if you're a visitor, where I grew up, there was that saying that if a visitor is seated in the guest room, you may be here conversing, but actually his other world, his other attention could also be outside. What is happening in the kitchen, what is going on. And if there is some good noise there, they will actually give you more good stories will come up. They will tell you one good story after another because they are happy. The other side is also doing very well. So, what is in the kitchen? What is coming up in regard to transfusion in children? There is a study that is looking at volume. We have already seen from the guidelines of the WHO that there are gaps, especially in regard to volume. Currently, there is a clinical trial. It's called a TRACT trial. It's a multi-center study in Uganda, Kenya, and Malawi. Kenya has not yet started enrollment. In Uganda, there are about 3 centers, Mulago, Mbale, and Soroti. Malawi is quite ahead of Uganda, but we hope Kenya will start enrollment. And they are trying to question this guideline. They want to provide sub-Saharan evidence. WHO are telling us that give red cell concentrate at 10 mils per kg or whole blood at 20 mils per kg. Is this with evidence? So they are comparing 20 versus 30 mils per kg of whole blood, or 10 versus 15 mils per kg of packed cells. And we cannot wait to see the results of this study. They have so far enrolled about 40 patients, and the population is quite big, about 2,000 or so. And the outcome, of course, there are several outcomes, primary and secondary outcome measures. There are also other new technologies trying to monitor patients under transfusion. And Dr. Zik yesterday highlighted about one of the equipment we are using in the acute care unit to monitor these children who are undergoing transfusion. This is what we are doing. We are trying to monitor their oxygen delivery to the tissues. The work of the RBC is to deliver oxygen to the tissues. And so once you are providing the RBCs, what is happening to the tissues? Are they getting the oxygen they need? So there are probes. These are probes. One can be put on the head to monitor the cerebral oxygen delivery. And then the other probe can go on the muscles. You can use the thigh muscle or the thinner. You can also monitor other organs like the spleen. And so you are aware you can be able to see what's happening at the tissue level in regard to oxygenation. And this is what happens. So after, when you start a transfusion, of course, their oxygenation, this is tissue oxygenation. This is different from pulse oximetry, because pulse oximetry just measures how well the RBCs are circulated with oxygen. But here we are looking at the tissues. Oxygen is for the tissues, not for the RBC. The RBC is just a messenger. So this equipment is very good because looking at who needs the oxygen, the tissues. So this is one patient. That other patient have shown down. So at the end of the monitoring, we come up with curves. Before transfusion, this patient oxygen, the circulation to the tissue was as low as 40, very low. The normal should at least be above 80. Like if we put these probes on you, the tissues are getting oxygen at that rate above 80%. So this patient is actually severely anemic. And that means the tissues are also not getting enough oxygen. So as you transfuse, you see how the RBC that's getting into the body, how well that is happening. There is improvement in the tissue oxygenation. Why? Because you are providing. And so on the y-axis, we see time of transfusion. So you see the great impact that you can actually make over the first 40 minutes of that transfusion running, an increase by 20% in the oxygen circulation. Of course, later it kind of curves off, and there are several predictors to this, So a lot can be done, and we can do a lot to monitor these patients and see, to have the evidence. So in summary, we can see that the guidelines we have, most of them have gaps, and we have an opportunity to generate our own evidence. And what is the future? How best can we monitor transfusion? How best can we monitor what we are giving? You know, because every treatment must have goals, and you cannot know where you have reached without monitoring. And there are several opportunities. We can do so many clinical trials. Tract is only looking at volume. How about the other aspects that we have seen in the guidelines? We have not touched any of them. And the sky is not even the limit. Thank you so much.